Our discussion have been over this past 3 days, and those are innovation, partnership, and inclusion. And during today's session, we will talk about a new initiative and an area, a very important area of work that brings together these 3 words really nicely. So we will hear today from countries and experts on innovation, innovative approaches on measuring adult mortality, using data from surveys and censuses, while continuing, of course, to improve what we just heard this morning are the foundational data programs, and that's, in this particular case, civil registration and vital statistics systems in countries. But we also talk about partnerships, as we are today launching a new community of practice on adult mortality measurement that will bring partners from academia, national statistical offices, health ministries, and several other partners to share innovative approaches, knowledge, and bring this work forward. They will also inform further methodological development in this area for all countries to benefit from. And then the third word, inclusion, which is, many of you who know me know that this is very close to my heart. For countries that do not have a good civil registration and vital statistics systems, adult mortality, especially on some particular groups of the population, are very rare, and therefore, for instance, include mortality at older ages. And as many countries are aging, that is incredibly important. And you will also hear later from our colleagues, Rachel Bevan, Director at Statistics in ESCAP, that there is an inequality also in the way we register deaths. So even in those countries where the system is quite advanced, there's still quite a significant level of inequality. And how we can address that through measurement and innovative approaches. So before I introduce the wonderful panel we have today, I'd like to recognize the incredible work of Stefan Helleringer, who's really has been the leader, I think, in this area of work since the time we established the working group under the technical advisory group on COVID-19, the measurement of COVID-19 mortality. That was established together by the UN Department of Economic and Social Affairs, including our division, statistics and population division, and WHO. But also, I want to thank especially all our partners, but especially ESCAP for their support, and in particular for their support in establishing the community of practice, which will be described during the presentation by my colleague, Aoi Chen. So we'll hear a bit of details. And thanks to all our colleagues in ESCAP, and in particular to Rachel Bevan. So now allow me to introduce the speakers, and just remind you that you each have 8 minutes, with the exception of Aoi, who will only get 5. So, first speaker is Stefan, as I said. So please, the floor is yours.
Thank you. And oh, okay, I should share my. Yeah. Can you see my screen? Okay. Can you hear me?
Yes, we can. We can see your monitor. We can hear you. That's fine.
Okay, wonderful.
Please go ahead.
So, thank you very much for the invitation to talk, and greetings from Abu Dhabi, and my apologies for not being there with you in person. As we start in this session, I wanted to remind most people that surveys and censuses in many countries do constitute the primary source of data on adult mortality due to limited levels of completeness of the civil registration and vital statistics systems. And these survey censuses have long established methodologies, protocols, and recommendations as pertains to the measurement of adult mortality. So surveys like the Demographic and Health Surveys, for example, routinely include sibling survival history that generate data on adult mortality by asking respondents about the vital status of their siblings. Censuses and survey also frequently ask about deaths that might have occurred in a household over the past 12 months. And demographers and statisticians can then use this data to reconstruct recent levels of adult mortality. Now, unfortunately, these methodologies do not meet many of the current data needs for adult mortality. And there are really three kind of confluent factors that made these limitations salient. One is the SDGs and the new indicators that need to be monitored for progress towards the SDG. Another one is the COVID-19 pandemic. And the final one is the renewed emphasis on the development of CRVS system. In terms of the SDGs and adult mortality, the data we do have from surveys and censuses are somewhat limited because they do not adequately cover a lot of older age groups. So, for example, data on siblings generate very few reports of deaths above age 60 or 65, for example, and that makes it difficult to assess older age mortality. These surveys and censuses also document few circumstances of risk factors of adult mortality beyond generally pregnancy-related mortality, and it makes it difficult to assess several key indicators. And finally, they only allow limited disaggregation. So, for example, in surveys, the data we collect on siblings is generally limited to age and gender, and we do not know more about the education level of the siblings, their residence, and so on and so forth. In terms of the COVID-19 pandemic, this global event has generated a need to detect now what we call short-term fluctuations in mortality, or periods of excess mortality that might last from a few weeks to a few months, or some short time interval. And surveys and censuses are generally too infrequent to allow this. And they also have sample sizes in the case of survey that are not sufficient to detect those short-term fluctuations. Rather, they only allow us to measure rates over rather long reference periods of several years. And finally, in terms of the CRVS agenda, contrary to birth registration, which is an area that now has questions routinely included in surveys and censuses, for example, about whether a child has a birth certificate, death registration is an area that is very rarely covered by surveys and censuses. So as a result, we do not know which deaths are registered, which deaths are not registered, and what might be some of the reasons for registering or not registering deaths, and that might limit our ability to orient and evaluate progress towards towards universal death registration. So in short, then, there's a need for innovation in surveys and censuses, because most likely over the short term, they will remain the key tools that we have to fill knowledge gaps about adult mortality. And without innovations in design and implementation, we will fall short of those needs for more data to monitor SDGs, the effects of the COVID-19 pandemic, or the CRVS agenda. Of course, some of these gaps might be filled statistically by global models and projections with all the attached uncertainty and potential bias or errors attached to them. And other gaps will remain blind spots, unfortunately. So what might those innovations look like then? In surveys and censuses, I'll argue that they can occur in multiple areas. For example, we can have innovations in questionnaires, what questions we ask and how we ask them. The mode of administration of surveys might also change, maybe to allow collecting data more frequently. Sampling might also require innovation. So who gets selected to participate in a survey, and with which probability? There might be innovations in linkages and integration with other data sets, and finally innovations in analysis. And I'll give you just a couple of examples of such potential innovations from past work that I've had the privilege to be involved in. One concerns how we might measure deaths related to HIV in countries that are affected, in particular by generalized HIV epidemics. So in most such countries, our estimates of HIV-related mortality comes from extrapolations from data that we do have on HIV prevalence and the coverage of treatment against HIV. We do not have direct data on such deaths. And one thing with colleagues from various research institutions in Malawi that we tried to assess was whether or not we could augment the existing questionnaires about adult mortality to include questions about the HIV status of deceased siblings, so that we might measure the proportion of deaths that are related to HIV or the excess mortality that people infected with HIV might experience. So we tried if we could add questions about a recently deceased sibling might have been tested for HIV prior to death, what might be the results of the most recent test, and some level of assessment of the likelihood of infections. And we tried different modes of administering this survey. One was by having an interviewer asking questions directly. Another one was more confidential and asked people to complete the survey on a tablet using headphones to hear the questions. And what we did find is that people were ready to answer those questions. There was very limited missing data. And we obtained levels of sensitivity and specificity that were very high. So we were able to characterize an HIV-related death with levels of precisions that were similar to what we obtain in validation study for pregnancy-related deaths. So questions that are integrated in virtually all surveys and censuses that measure adult mortality. And it also took very limited time to ask these questions, less than a minute per reported death. So it's very feasible to integrate those questions in surveys and censuses. Another example has to do with mobile phone surveys in that case. So as you all know, at the beginning of the pandemic, many studies and institutions shifted to administering surveys by mobile phone because that's what that mode of data collection was feasible. But at the time, there were two widespread concerns related with the measurement of mortality. One was that questions about mortality might be too sensitive to ask by mobile phone. And the other one was that the mobile phone surveys should be kept short. So there would be no space for mortality question. So we tried to investigate those two questions through small trials again. One was done in Malawi with approximately 2,500 mobile users selected via random digit dialing. And what we did in one control group, we asked them questions solely about economic activity, which is a topic that is considered widely acceptable in mobile phone surveys. And in a treatment group, on the other hand, we asked mortality-related questions, and we monitored the proportion of people who consented to the survey, who completed the survey, who reported experiencing negative feelings, and participating in future survey. And on all those outcomes, we found that the mortality-related questionnaires was not inferior to the economic activity survey, meaning that we obtained participation outcomes that were just as good as the other survey that we compared to, and that was widely conducted throughout many low and middle income countries. So thus establishing the acceptability of that methodology for data collection. And so based on these examples and the need for innovation in the collection of adult mortality data in surveys and censuses, I think in terms of way forward, there's a really urgent need to stimulate new ideas in design, implementation, and analysis of surveys and censuses as they relate to adult mortality. And hopefully this is something this new community of practice might do. And there's also a need to establish really a pipeline from ideas to implementation, to tests to implementation of these ideas on these new methods on a large scale. And that requires also conducting careful and conclusive experiments, for example, in randomized trials or validation studies against gold standard data. That, of course, requires seed funding to conduct such experimentations. And finally, I think there's a great need for collaboration between national statistical offices, academic institutions, global data collection programs, and other partners that might have a stake in the collection of adult mortality data, so that what we do find as effective methodologically to generate better and more complete adult mortality data might rapidly be adopted on a large scale and help measure progress towards the ADD and assess the impact of global events like the COVID-19 pandemic. And I will stop here. Thank you.
Thank you so much, Stefan. And thank you also for highlighting the importance of promoting innovation and finding ways to fill the data gaps, especially when it's so urgent in the case, such as in the case of COVID-19, while at the same time finding ways to improve what we call the foundational programs and using the results to advance the work on the strengthening of civil registration and vital statistics systems. Also, I failed to introduce you, I think, Stefan, but you've been terribly helpful. He's a professor at the New York University in Abu Dhabi, and he hosted also our first workshop on this topic last year, where we were able to bring together many good experts to address this topic. Next speaker is Leonardo Trujillo, Deputy Director of EDANE, and he's here with us in person, and he will talk about the measurement of adult mortality in Colombia. Over to you.
Good afternoon, and thank you, the organizers, for letting us join this session today. I'm going to talk about the calculation and estimation of adult mortality in Colombia, more referred to the pandemic times. This is an example in Colombia of how to combine surveys, censuses, and administrative registers in the country. This is an interinstitutional coordination process for the evaluation and reclassifications of deaths due to suspect COVID-19. So, according to the World Health Organization and the Pan American Health Organization, there are some definitions and guidelines for coding deaths for COVID-19 as follows. First, we have identified virus. These cases confirmed by positive test result, and also unidentified viruses. These are cases that are suspected to be due to COVID-19 by clinical diagnosis, but there is not a confirmed by a test. So the Ministry of Health, when we have these unidentified viruses, the Ministry of Health convenes a committee to reclassify cases. This is done integrating many administrative registers in the country. This is the case of this administrative register for disease surveillance that is called Civigila. In this register, we have all the health events in the country, and combining with the information that we have in the National Statistical Office, we can get a more complete database. But also, through the determination of epidemiological linkages, that means when people have been in contact with suspected cases of COVID-19, this is according to a field study. I'm going to explain a little bit more later about that. And also through the analysis of documents, mainly medical registers and medical documents for patients. And when we analyze all this information, then we can reclassify the case in another administrative register that is called the RAF. RAF is the register for all the affiliates to the health system. And then we can discard suspects that are reclassified by a different pathology, or we can confirm suspects reclassified to death by COVID-19, and then with this final database is that DANE works for this CRBS statistics. So this is a little bit more about the process. We have worked with a format that is called SecCovid. SecCovid is an applicative or a format in order to establish whether the suspected COVID-19 deaths are caused directly by the coronavirus, by concomitant infection, or by different causes. The responsibles of filling this format are vital statistic managers, public health officials, or medical auditors. And the idea is to work first with these unidentified cases through medical documents, and then we are going to work with this another administrative register called RIPS. RIPS is an administrative register in the Ministry of Health that have all the medical events and all the treatments for a particular patient. We work with a key variable in order to match all these databases, that is the national identification number. Even in our census, we don't collect that variable, but through matching processes, we can identify the identification number for a patient, and then we can also recover other variables, like, for example, telephone numbers, addresses, and location of the family of the patient. When the RIPS doesn't have this information, we use other administrative registers, like, for example, SysMuestras. SysMuestras is the administrative register that we worked during the pandemic in order to have all the tests, COVID tests that were implemented in the country and the results of all these COVID-19 tests. And when none all of these databases are working, we have finally a last option, that is go to a verbal autopsy. This is an interview for these very particular cases, very small number of cases, when we cannot get the information of some patient that has been an unidentified case. And for this very particular set of people, we are going to have specialized interviewers to collect information about signs, symptoms, and demographic variables in order to match the information with all these administrative registers. But we also work with the national census, because the national census combines about 21 other administrative registers in the country and 2 surveys, the labor survey and the quality of life survey. And with all this information, we get the basic administrative register of population. As I mentioned, it's a combination of the national census with 21 administrative registers and 2 surveys in the country. It's called REP. And with all this information and the last step, that is the verbal autopsy, then we can return to the RAF, that is the administrative register with all the affiliates, and then we can get the source of information if a suspicious case had been detected as a COVID-19 case. All this process of integrating all these censuses, surveys, and administrative registers led us to get all these indicators. For example, the total number of deaths due to confirmed and suspected COVID-19 and deaths due to influenza. Also, the gross and specific mortality rates for confirmed and suspected COVID-19 for 3 years so far, because the CRBS is an annual statistical process, so the last one was for 2022. Also to monitor mortality, and also to calculate the excess mortality. This is also done because you have to calculate the difference between the cases due to COVID-19 to the estimation of if there was no pandemic in the moment. So in order to get that, you use time series methods with the historic data, and then you can get the excess mortality calculation. You can also calculate maternal mortality associated to COVID-19 and deaths due to the multisystem inflammatory syndrome associated with COVID-19 and analysis of comorbidities associated with death of COVID-19. The main comorbidity associated to COVID-19 deaths was high pressure diseases and second respiratory diseases in the second place. Still, we need to work more in this integration of information because we know administrative registers are not full coverage. There is sub-registration of all the cases. So similar what we do with censuses, we need to estimate like the omission of people that we have with all this exercise. And for that, we are trying to propose a vital statistic coverage survey because we have the opportunity to work with the telephone numbers obtained for all this combination of information. We are planning to work with the London School Hygiene and Tropical Medicine in a rapid mortality mobile phone survey, similar what the last speaker was mentioning. We are only in the costing and planning stage of this project. We want to carry out a pilot test in some prioritized territories, for example, indigenous territories, because they are demanding us to get this information for them, and also to exchange and crossing of complementary databases, for example, with the National Health Institute and with the, in Colombia, all these vital statistics come from death certificates, but there are two institutions that produce death certificates. One is Medicina Legal, it's like a legal medicine when you have deaths produced by violence, and then you have like a forensic process to get the death certificate. But also when you don't have a violent death, but if you have a medical certificate, or even if you don't have a medical certificate, there is another institution called Registraduría, and that is the institution in Colombia that provides this death certificate. So we need to work with both sources of information for death certificates. And the last one is REVP, that is the one that I mentioned that combines the base population register in the country. Thank you very much.
Thank you so much, Leonardo, and so interesting to hear all the great efforts DANE is undertaking to improve this data and also to expand the civil registration and vital statistics covered. So next speaker, if we can get her on the video, is Nandita Saiki, a professor at the International Institute for Population Sciences in India. Can you hear us, Nandita? We don't see
Yes.
you. Okay, perfect. And she will talk about adult mortality estimation, indirect method on survey and census data. Nandita, you have the floor. We can't see you, but hopefully you can share the screen, your presentation.
Yes. Can you share? Can you hear me?
Yes, we can hear you.
Am I audible to you?
Yes, we can hear you well.
Yeah, great. Yes, thank you for invitation.
Okay, perfect.
Yes, it's very interesting to see the previous speaker, to hear the previous speakers. Quite a lot of stuff are already very much applicable in India, particularly Stefan's methodological address. And I would take forward from that how survey data can be used to understand death registration, and then what is the way forward. So I'll be speaking death registration coverage for population subgroups in India during 2019-2021. So as we know, CRS data is extremely important. It is the best investment and for any development purposes, for policy making, resource allocation, particularly country like India, which is huge and extremely diverse by socioeconomic characteristics, by geography, and by administrative policies. Moreover, it gives also legal rights, as we know, for adult death, for example, if there is a property dispute after death, this death registration certificate is needed. For pandemic like COVID-19, it increased further the importance of CRS data, civil registration system data, because we need dynamic data and timely data, and perhaps if not weekly but monthly data at local level, because we see that in India, COVID spreading, there was no such very big pattern, in a systematic pattern. It was anywhere and everywhere. So, and finally, we know that SDG indicators are 17.19.2 calls for 100% of birth and death registration by 2030, birth registration 100% and 80% of death registration by 2030 for monitoring statistical capacity. So what is the system? What is the status of civil registration system in India? So far in India, we have a number of statistical systems which can give mortality data. One is mostly used is sample registration system data. There are health management information systems. There are many surveys which also conduct regularly mortality related survey. But CRS has been existed simultaneously. The number of registered deaths recently went up from 7.64 million deaths in 2019 to 8.12 million in 2020, an increase of 6.3%. Interestingly, the Office of Registrar General report says that death registration in India has increased up to 92% from 2019 in 2019 from 85% in 2018. However, 92% death coverage in civil registration system is a bit debatable, and we will see whether there is a match of this number with a big survey which is called National Family Health Survey, whether there is a we can conclude the same from this two data set. So our objective is to aim to investigate the disparity in death registration in India by districts and socioeconomic characteristics. We used National Family Health Survey 2019-2021 to provide, which gives us the information on the number of deaths in a household since 2016. Family members who experienced death, the death of a member of their household, were asked if that has been registered with the civil authority or not. The sample included 84,390 individuals who died 3 years before the survey. So this data was actually collected in the household roster system to know that whether there is any death in last 3 years of the survey. And when we estimate what is the death registration level among men and women in India, 2019-2021, here is the picture. There, first of all, there is a huge variation across districts of India, from less than 40% to 100%. In fact, it is also possible, that point I'll come later on, but according to out of this 84,390 sample size, death registration percent varies less than 40% in certain districts of northeast areas to 100% in some of other districts in the southern part. And we see that there is quite a gap between men and women's death registration. Generally, women's death registration is much lower. Almost all districts, there is difference. Women have lower death registration compared to men. When we see how death registration vary by demographic and socioeconomic characteristics, we come to this picture. We see that death registration is pretty lower among young people, like 0 to 4 age group, 5 to 14, and so on. It is typically high for the adult age group, which is 35 to 49. And then it also reduces further we go for old age. We see that there is a gap between men and women, male and female, 75% versus 66%. Urban population have higher death registration. And when we go for geographical location, big regions of India, we find that south and west population have higher death registration compared to, like, other states and other regions, and particularly it is lower in the central, like big populous states of India and the eastern part. And we see that there is no information about the diseased person's education, but if we calculate what is the death registration by household heads education, we find that as household heads in education increases, death registration also increases. We see that when wealth index of the household increases, there is a higher reporting from 52% to 87%. And we see that across different religion, there is a great difference. Muslims have lowest death registration, whereas people from other religion like Christian, Sikh, or others, they have higher death registration. Across the socioeconomic caste group, social characteristics, which is a social characteristics, we find that there is some difference, but it is not as much. Like there is the gap between deprived caste is not much, but if we go for other general caste, we find they have better coverage. And nuclear, non-nuclear family, we see that nuclear family are having higher death registration. Also, we have seen what is the death registration by below poverty level card. If a household has below poverty level card, whether their death registration is lower or not. And we see that those people who are from below poverty level, they have a slightly lower death registration. And because there is also information about the bank account availability, we have calculated, and further health insurance we have calculated, and we see that wherever like death registration is always positively associated with household socioeconomic characteristics. As socioeconomic characteristics are improving, death registration is also improving. And here, then we try to find out what is the net impact, net association of socioeconomic characteristics with death registration. And results are more or less same in the same direction. Basically, we see that as compared to youngest age, adult age group has highest likelihood of death registered, even after controlling other factors. Female have still lower chance of death registration, and rural, similarly, Muslims or people from poorer household health wealth index or education. So results, what we are seeing already in the bivariate distribution, it is almost valid for this. And now this is what until this time I presented only data from NFHS data, from findings from NFHS data. But now what is the whatever NFHS data is presenting? This is a survey data. Is it in the line of civil registration system data itself? So what I have done here, using Brass growth balance method on civil registration system data, mortality data, I tried to estimate what is the coverage at state level, and I'm comparing with that of NFHS. So what we see here, it is interesting that when, in India, CRS data gives us numerators, number of deaths happening across state at different age group, and that data I have connected with corresponding census data to calculate. Yes.
Sorry to interrupt you.
Yeah, I'm almost done.
Slide. We still see the previous slide. I think you missed two slides.
Is it here? No, it is.
Just
let
give
me
us
share
a second
again
to figure out what's going on. we are still at the slide with the socioeconomic characteristics and the differentials.
Okay. Are you able to see now?
Not yet. Okay, it's coming up. No.
Yeah.
No, you're sharing your
Is it
screen, but
coming?
another window. We're seeing your email.
Okay. Yes.
Just move to your window on the PowerPoint.
Yeah, just move to the PowerPoint slide. Go to the PowerPoint slide. Now you're sharing your email boxes.
Enter screen.
Just move to another
Is it
window.
now?
You should be okay.
Is it working now?
It's still your email box. Can you just move your to the other slide that has your slide? Okay. Yes.
Yes. Is it? Yes. So did you see my this table? Okay, this I already completed. I'm going to show the comparison between brass growth valence method estimates, which is based on completely CRS data and census data. And I'm comparing that estimate with NFH's debt registration comparison. So here, of course, in some of the states, we find that, debt registration is higher than 100%, say in Delhi, particularly some states like Delhi, it is more than 200%. So what does it mean? That it is possible in the sense that because a lot of neighboring states debt registration come to urban areas, and that it may increase. So but the point is that wherever we are finding, say for example Uttar Pradesh, according to NFHS, debt registration is somewhere 65, whereas for from indirect estimation it is 58. So if we go for comparison, we find that there is a huge concordance between agreement between these two graphs. So what I want to say that what NFHS has collected data on debt registration, this is more or less pretty valid, and we can use this information further. So what we find from our analysis is that there is a huge variation by districts and socioeconomic and demographic characteristics. There is if we see the CRS reports, we find that there is a continuous increase in the coverage, but it is far lower than what is estimated according to what is shown in CRS report. In CRS report, as I said in the initial slide, that 92%, but which is not true. It is basically NFHS which is giving 70% coverage at national level, and our own estimate from CRS somewhere it is 65%. Then there is a from this study as well as from our previous study, we find that there is a still lower level of awareness among for debt registration. There are still administrative and technical challenges. Some states are doing very good. They are also giving some real-time data in dashboard, but still India needs a lot of technological innovations. And possibly because in India recently mobile penetration is extremely high. So if this debt registration can be directly done through mobile phone, perhaps it will increase a lot. There will be a huge increase in debt registration. At the moment, I'm also conducting qualitative and quantitative surveys in 6 different states of India, which comprise 6 different states from 6 major regions, and we have chosen states which have very high coverage like Kerala of debt registration, and states like Uttar Pradesh, Assam, where debt registration is very low, where we want to compare because we see that it is not just state differential but also intrastate differential. Districts from the same state have different level of debt registration. So we want to compare why 2 different states is doing different way, one good, one bad, as well as within state why some districts are doing better compared to others. So we want to understand that how the things are working, and that is one. And another is that we want to focus more on marginalized section, and for example more remote areas, as well as like we are focusing quite a lot on tribal population and why they are not coming to the system. So I think I can report all those once my study conducts completes. Yeah, so I want to share our paper, which is published in WHO Bulletin 1, death registration coverage. Another one is on +1, where we discussed using qualitative research data collection. We have analyzed the performance barriers of civil registration system in Bihar, where death registration is one of the lowest. And this two study one can find if those who are interested. Thank you.
Thank you so much, Nandita. That's certainly very interesting and really highlights the need to better understand inequality in death registration, and you show very clearly. I was shocked to see the big difference also along the sex difference between male and female, almost 10 percentage points, and from 52 to 87 from the poorest quintile to the richest quintile. So really huge differences. So next, we have Rachel Bevan. I already pre-announced her presentation. She's Director of Statistics Division at ESCAP. Rachel, you have the floor, and she will also talk about inequality in death registration. Over to you.
Thank you so much, and thank you for this opportunity. I should start as well by saying that this is work that's been done by my team and not by me. So a huge thanks to the team who have produced it all. And also going last, or kind of almost last, means I can skip over some of the slides because a lot of other speakers have already covered some of these issues. So I'm just going to talk about some work we've been doing on inequality assessments using survey and census data to actually assess whose deaths might not have been registered. So I don't really need to tell you about this, but obviously we know that there are a lot of factors which affect civil registration. Whereas with births, there are lots of incentives to actually register a birth. That's not the same case with deaths. And we saw very much from the slides from India about the different groups that are actually being disproportionately affected. So we know that death registration is lower amongst many of these groups. I'm just going to skip over that. But the other thing I think that's also important is that these factors are not existing on their own. They're very much kind of overlapping. So it tends to be, women from a rural community with a lower level of education. These factors are all compounding to actually mean that these groups are being even more excluded from death registrations. But that also means they're often being excluded from other things. And I guess more importantly, they're being excluded from policies that governments might be making to really help these people who are most at risk and most marginalized. And we know that COVID-19 as well really brought death registration into sharp focus, probably for every single country in the world. I mean, even within the UK, I know we had to really change a lot of the ways in which we were registering deaths because we'd never thought about some of these things before. We certainly had never considered ethnicity and recording that on death certificates, and then we realized actually we really desperately needed that information, and it is so much harder to do it afterwards, to then have to kind of get that information from other sources. So, even though we kind of know all of this, we also, we know that we haven't done very much work yet. So we're really only very at the kind of early stages of really exploring in a bit more detail about, which are the groups that are being most left behind from civil registration and vital statistics systems. So even though we know groups are being left behind, it's been quite difficult for us to actually work out, which of those particular groups it is. And there are different reasons for that. And one of them is that actually it's difficult, but also there hasn't been much guidance on how to do it. And that's one of the things that we've been looking at doing through this work. And I should also say a huge thank you to Bloomberg Foundation, because they're the ones that actually provided us with a lot of money to really work with countries in Asia Pacific to improve civil registration and vital statistics systems. And without their support, we wouldn't really be able to do this work. And it is, absolutely so important. One other thing I just wanted to say at this point as well is that when we talk about universal coverage, we really do mean 100%. We don't mean just 99%. And sometimes countries just stop and think 99% coverage is good enough, but it certainly isn't good enough. That other 1% really do matter, and they probably are the most marginalized, the most disadvantaged groups. So we must make sure that we don't just stop at the 99%. It's also important, to note that the impact of exclusion from death registration can actually increase as the coverage and completeness increase. And that's because the remaining unregistered events may actually be further concentrated among those specific subgroups of the population. And that means there can be even greater relative disparities in death registration. So, if I can then say a bit more about this project. So with the money that we kindly got from Bloomberg, we've been able to actually look in a bit more detail about CRVS systems and about inequality assessments. So using other data sources, we've actually been able to then look at which groups are being most left behind. And as we've been doing that as well and working with countries, we've also been developing guidance on how to do this. So we've just completed inequality assessments in Laos and in Fiji, and we're just about starting the work now in Bangladesh and Pakistan, and we are at the very, very early stages in Samoa and the Philippines. So once, as we go on, we'll be able to say more and more. So this is very much just a kind of early findings. So from the work that we've been saying so far, the two that we've completed, we've been working in Fiji and in Laos. And what we were trying to do was to use data on births and child mortality and adult mortality. But I think what we quickly showed is that actually there wasn't very much other data on adult mortality, as we possibly knew already. The work in Fiji as well, we were working with the Ministry of Health and using administrative data from that particular system. So I'm not going to talk about that one in detail. I'm just going to concentrate a bit more about what we did in Laos, just to kind of show you a kind of emerging findings, and it's really to just show you what can be done. So in Laos, if I go on to just saying a bit more about what we actually did. So we used data which was available from their social indicator survey from 2017, so it's not that recent, and where we used information as kind of has been talked about earlier. We used the information that people were providing on infant and child mortality, and we estimated that from the information that was being asked from the women, which looked at birth histories and had asked specifically about recording all deaths from children under the age of 5. So when we kind of looked at that information, we then looked at the most suitable model life tables, and I'm definitely not an expert on model life tables, so I'm going to ask anybody else to answer any questions on those. But we looked at those to identify the kind of closest expected age mortality pattern to the one that we expected to see in Laos at the national level. And then using those life tables, I know it's getting a bit complicated, we looked at then the UN World Population Prospects, kind of estimates of population by sex, and in this way we're able to actually look at the total number of deaths that have been calculated then for Laos for 2016 to 2020, disaggregated by sex. So this next slide shows you what we did. It's a bit complicated again, isn't it? We've got a few lines here, but each of those lines, so we can see male on the left and female on the right, and the different lines just refer to these different life tables. But in this, you can actually see the age and sex-specific mortality patterns according to these different life tables that have been used. But we can see actually that the curves are very similar, and the patterns are actually quite close. So having done that, we then estimated death registration completeness for males and females from 2016 to 2020. And rather than actually just choosing one particular life table, here we're showing estimates. So it's a little bit complicated, isn't it? So looking back in 2016, we can see it for males and females. So we think that the level of kind of death registration completeness for males was somewhere between 32% and 44%. And then by 2020, that's actually gone up to something between 37 and 50%. And for females, actually the rates there were a bit higher, and they've gone up to somewhere between 42 and 62%. And that range, as I say, just depends on the particular life tables that we were using. And although this gives a range, I think the point about this is it's giving us some information that we just didn't have before. So we know that this isn't giving us the kind of point estimate, it's not enabling us to work out exactly what the number of deaths were, but it is giving us some further indications. And this is very much our kind of first try at doing this in one country, and we're kind of carrying on doing this work in other countries. So we really are seeing this as the kind of the start of the research. So we're sharing it with you, I'd say, at a very early stage. But it really, we want to kind of use it to try and help us to actually assess and look at how we can improve this as we go on. We did have some lessons, as ever. We've learnt some lessons as we've gone along. The first of these, which is probably the case for all kinds of topics, data integration is not easy. When we're trying to combine the data sources from these different places, of course, that means that we're often, it's not simple. We didn't just have kind of one identifier we could link. So we need to kind of coordinate. We also need to really understand the data at a very detailed level. Also, there wasn't very much data available on adult mortality. And another factor as well was the capacity. Perhaps as expected, capacity is limited. Particularly, this is talking about some pretty technical areas. It's certainly beyond my technical knowledge. And that means, we have to really work with countries to help them to do this, and need to kind of work together on these things. I think also it really showed the importance of having national champions and that they can make a difference. But what we also know is that we can do it much better if we work together. We know that we can also improve the methods if we look at different countries, different contexts, then we can very much learn from each other. And we're planning to, as I say, carry on this work in the other countries and to carry on looking at what we can do to improve the methods. As in all of our work, we try to share it as we go along, so there'll be lots of opportunities, to engage on that. And we're establishing this community of practice on measuring adult mortality. And again, that is very much to really build on what's being done already, but hopefully as well to produce more guidance and more help for countries so that we can move forward on this together. Thank you.
Thank you so much, Rachel. We won't put you on the spot with very difficult technical questions. I do have some, though. Maybe I'll keep them for later. So, last but not least is our colleague Aoi Chen from the UN Statistics Division. She's also the coordinator of the Intersecretarial Working Group on Household Surveys. Aoi, you have 25 seconds left.
Yes, so not good, because it is true I don't need a lot of time because all the other speakers have spoken so much about it and they covered a lot of information. Just really a daunting fact that we, when the work tag, WHO UN-DESA Technical Advisory Group on COVID-19 Mortality Assessment, try to understand the impact of COVID on mortality, they found out 30% of countries, only 30% of countries had the required data for the exercise. So this stuff already covered. Why are we working on this topic? So I'm not going to talk about it. And just to say that Francesca had mentioned about the expert group meeting we had in Abu Dhabi, August 2022, and it was out of that expert group meeting, there was a recommendation, is there's so much going on, a lot of innovative approaches, let's establish a platform for us to work together as a community and to bring all together to establish this community of practice, bringing all the examples and case studies of what worked, what didn't work, to this COP we call community practice. So it was really coming from that meeting in Abu Dhabi. So that's a collaborative effort, and we have a lot of partners, and special thanks to our partner from Rachel from SCAP Statistics, and hi to our colleagues. I know they're watching from Bangkok. Thank you so much. We've had a lot of discussion online already. Thank you so much for all the work you put in, all the resources, and we invite all statisticians, demographers, National Statistical Office, from health ministries, research institutions, everyone who's interested and very interested in contributing and to learn more on how to enhance the quality and availability of adult mortality. And please join the community of practice. How do you do it? I have put a link to a registration form. So we're offering 2 kickoff meetings, one on the 17th of May, the other one on the 18th of May. So please enter and put and show your interest through the form. And then we look forward to talk to you through more details about the community practice. And that's about it. Thank you so much.
Thank you so much, Aoi. And unfortunately, there is no time for questions because we need to move to the plenary session in a few minutes. But the idea of this session was really to learn about what the work that's already been done, learn about this community of practices that is, I think, a very useful space for us to work together. So please, as I always said, get in touch with colleagues, colleagues at DANE who've done a tremendous amount of work, colleagues at ESCAP, ourselves in the UN Statistics Division, our colleagues at the NYU in Abu Dhabi, in India. They've all really shared very important work already being done. So please join us and get in touch if you have any questions, if you want to learn more. And thank you again to our great panelists. Thank you for your great presentations, your very important inputs. And see you in the plenary room in a bit. Bye.
Thank you all.
Thank you. Thank you for invitation.
Thank you, Sichi,
Bye.
for staying with us. Thank you, Stefan, Nandita.
Thank you all. Thank
And
you.
Pedro, everyone on the other side.